I love the Hawaii meeting. If you've gone, you understand. If you haven't, I'd recommend it. But I've been, lucky enough to give talks at that meeting in the past. And the moderator for the session, contacted me. Vance Thompson called me and he said, John, we'd love to have you talk again this year. And here's my only request. Pick something that you're passionate about and pick something that has changed the way you think about treating patients. And I want you to talk about it. And it's like, okay. And it ended up being easy. So the title of my talk is Rediscovering FLACS, Confessions of a Former Disbeliever. And I was absolutely, I was part of some of the initial studies with femtosecond lasers, and quite frankly, I sent the laser back when we were done. I just didn't think it was an expensive solution to a problem I didn't have, and did that for a number of years. And I have since now completely changed my opinion. And you mentioned you're using the Ally system. I am as well. It's a Lens AR system, but I think the other systems are probably as good, but the one I know about is the Ally. And right now we're doing like 35–40% of our patients are getting FLACS. And the reason is we're treating lower levels of astigmatism. And so, I'm kind of use this common sense where, would you prescribe glasses and forget about treating 3/4 or 1 diopter of astigmatism? Would you do that? And the answer is no. And if you're putting in a standard lens because you can't do a toric, you can treat that with the femtosecond laser. And, again, times being what they are, you can bill for that. And it becomes, one, a great asset to the patient in terms of the quality of vision, which is clearly better for having mitigated the astigmatic correction that they would otherwise have. And two, it's been a plus to the practice. Quite frankly, it's a center in which we have a premium option that people can afford. If they can't go for the other options, they can generally afford the AK option or with the femtosecond laser. So that's been one of the game changers for me, and I just had to throw that out there. And I don't know, Greg, what do you think? I mean, I know you use it as well, and
yeah.
What are your experiences been?
Yeah. So we're a big believer in the benefits of femtosecond laser cataract surgery and femtosecond laser RLE lens replacement as well. So we choose to use it for every RLE that we do. I really believe that it is a safer alternative to manual cataract surgery. And that is not to say that basic cataract surgery isn't safe. It's a wonderfully safe procedure. But if you made me say, which one do I think is safer? If I had to do 1,000 cataracts, would I rather use it or would I rather not? There's no doubt in my mind I would rather use the femtosecond laser on those 1,000 cataracts. There's so many things that you can mitigate that otherwise might make a cataract surgery challenging, whether it be a white cataract, a loose zonule, a patient who's moving around. I had a cataract surgery a few years ago. This was a case I didn't use femto on. And as I was starting to do the capsulotomy, the patient developed a pretty severe case of the hiccups. And so as I'm peeling my capsulotomy, I had to time it and hiccup and then pull a little more, hiccup, pull a little more. So, I mean, there's just things you can't predict what might be the reason you're glad you had the femto that day. But there's many of them. And from an astigmatism management standpoint, I actually do think the Ally platform does have benefits compared to the other systems, primarily because of its iris registration to the clinic diagnostic capability. So we use a pentacam. There's several different other diagnostic devices that can upload a photograph of the iris along with the astigmatic axis of the cornea. That data gets uploaded to the Ally system. And then with iris registration, when the patient is docked underneath the laser, it also sees that same iris registration detail and auto rotates to put either the AK on the cornea and or the toric lens in the exact axis of corneal cylinder. And there's no other platform that has that amount of astigmatic precision.
That's an incredible feature of the unit, though, because I mean, think about there's a stat, and I don't remember the exact number, but the amount of average cyclorotation by placing just somebody's head going in a supine position, it's several degrees that you can actually have cyclorotation. So from an optometric point of view, I mean, Jenny, you know as well as I do, a contact lens that rotates 5 degrees, especially in somebody who's got a diopter or two of astigmatism, that's a problem.
Yeah.
You know, we have different ways to compensate for that with contact lenses, but in surgery, you really don't. If that lens is off by 5 degrees, there's only one way to fix it, and that's to go back in and re-rotate it. So the ability, I think, to get astigmatic correction and management on the degree of access, you know, without having a whole lot of deviation is just huge. So talking about the different technologies, we've already hit on a bunch. Jenny, maybe you can comment on this. I mean, using a femtosecond laser-assisted, astigmatic correction with the LAL. The LAL does have certain limits. Mm-hmm. So can you talk about the limits of astigmatism inclusion for LAL and
so
how
with LAL we can treat down to 0.5 diopters of astigmatism, but up to, I've really pushed the limits and I've hit 350, but sometimes, you know, things go awry and we have, you know, they find out that there's more. I think that the AKs and LRIs really help those patients with the higher amount of astigmatism. So a lot of our surgeons are already just proactively using that so that I don't have to try to cross my fingers and treat that amount of astigmatism each time. So it's been very helpful and a game changer.
What do you think, when do you start recommending? I mean, at what level? If somebody's got like a diopter and under, or diopter and a half and under, you forego AKs?
I say 150 and higher will just kind of help the patient's journey a little bit quicker, just because with the light adjusting treatments, 175 and higher usually will take multiple treatments to get down to plano then.
Yeah, so what you're doing, if you can debulk astigmatism at the plane of the cornea, so patients who in our practice, anybody who's a diopter and a half or more, we'll always recommend a FLACS treatment, and we use that pretty routinely. But really pushing for it in patients with a diopter and a half or more, because if you can get that down to a more workable value, you're preserving the finite number of macromers that exist in the lens. Remember, that lens is made up of a finite number of macromers, and the more you use to treat astigmatism, the less you have to move in a plus or minus direction. So you want to preserve that number if possible. So a diopter and a half is kind of where we put it. I mean, I could definitely see an argument for even less than that, just to give yourself enough wiggle room if you need it. So a short eyeball, if you got somebody who's like my +8, patient, that if you're going to be off, you may need more macromers to work with. So maybe more quickly go towards an AK inclusion. So back to astigmatism. I mean, at what point with not doing the LAL, if we're doing just a monofocal lens, is there a difference with how you manage astigmatism based on the degree? With the rule, against the rule, oblique, when do you consider when it's worth treating? Greg, maybe you can start there.
Yeah, so there is a difference between with the rule and against the rule. So that has to do with where we're sitting and where, typically I sit temporal. I think most cataract surgeons sit temporal these days. A few will sit superior. But if we're sitting temporal and we want to make an arcuate incision nasal in an against the rule case, it can only be so large. And so we have a different threshold where we'll go to a toric lens if it's an against the rule patient. So, we might put a toric lens in even if there's only about 0.8 diopters of against the rule astigmatism. Whereas if it's a with the rule patient, we'll put a toric lens starting at about 1.5 diopters. And less than that, we can use arcuate incisions to reduce the cylinder. So there's definitely a difference there. And then to your question about how much should we treat? I mean, I go back to the point that you made, John. If it's enough that I would put it in a spectacle lens, why wouldn't I put it in something permanent like a surgical lens that I'm prescribing to the patient? So I want the patient to have the absolute best quality of vision. I think that, as you mentioned earlier, Nick, treating refractive error closest to the nodal point of the eye produces the best quality of vision. We see that with high myopia and ICLs compared to treating the cornea. Same thing goes for astigmatism. If you can treat that refractive error closest to the nodal point of the eye, you're going to produce a better quality of vision than you would if you put it, like ½ inch in front of an eye in a spectacle lens.
Yeah, I think those are all great points. I mean, the ability to treat astigmatism, and you can almost like kick into the wind, right? Based on their age and where they're going to probably drift. And I think that's kind of where we are in our practice too. If it's against the rule, we're more likely to do something quicker. If it's with the rule, we usually can leave a little bit, expecting them, depending on their age, where they're going to drift and how they're going to change. John, talk about how you present that to patients. How do you even present astigmatism? That's such a big word. Everybody thinks it's almost the equivalent of cancer, right? It's just a terrible thing. How do you talk to patients about it?
Most patients, they may not understand what astigmatism is, but they know that their glasses were a little bit more expensive or their toric lenses were special and had to be fit specially. And so it's just another component of what makes a blur. And then I'll meter the technicality of the discussion based on, what the patient really wants to hear. And you can get as wonky as you want, but I try not to overload them with, what the optical issue is, other than it's just one more thing that creates a blur. And unless we correct it, you will not have clear vision without the need for something to correct it. So I try to keep it simple, and I've established, kind of a sense of what patients want to hear in terms of how deep you want to dive. But I will certainly tell them, again, as we've mentioned before, that, look, you've had this correction in your glasses, in your contact lens. It's always been there, and it's there for a reason. And we're going to do the same thing with your implant or with the correction of the astigmatism using a laser, which is very accurate, and that will give you the result that you're looking for. And so really, at the end of the day, I don't think patients care how it's done. I think they care about the result. And that's what they'll remember, is the end result. And that's what creates patient satisfaction and word of mouth referrals. And I guess I can tell you that 2 years ago, if someone had asked me, well, do you think you'll ever really use a femtosecond laser in your practice? I probably would have said, there's no way. I'm doing just great. Thank you very much. And it is now an incredibly important part of what we do. I mean, like I said, it's like 30 to 40% of our cases are done with a femtosecond laser. And that is only driven not because it's a marketing tool or not because it's a laser. It's because we're getting better results. And that is, the end of the day, what you need to be able to do. And this is what allows us to get that result.
It's incredibly important, especially in so many, John, you as well as I know, that most of our patients are post-LASIK. And some of the LASIK that was done 20 to 30 years ago was pretty aggressive. And there's a lot of higher order aberrations in these corneas. So the ability to have a central capsular rhexis, have a lens that's not going to be tilted, you're not going to induce coma, you're not going to have as much trefoil. It's just imperative. And now we have technology like the LAL that we can really modify things. However, the lens still has to be centered, and that's where the capsular rhexis comes in play. So many of our patients have these corneas that have already been not screwed up, but they've been amended.
It's a little strong.
They're dealing with maybe not, Well, I mean, looking back, I wish you hadn't had the LASIK, because this makes it a lot more challenging. But now we have the ability to really, address it and modify it.